schizophrenia may be one of the most misunderstood of all mental illnesses by the general public. Well, this show is all about putting an end to that. Get the facts from our experts who will be joining me in demystifying schizophrenia next on Speak Your Mind. Welcome to Speak Your Mind. I'm Dr. Carolyn Phelps, licensed psychologist with the Human Development Center. Living with schizophrenia and loving someone with schizophrenia each pose their own unique challenges that are complicated even more by the often cruel and at least misinformed stereotypes which accompany this illness. Tonight, we're debunking stereotypes and myths about schizophrenia so that we can be more informed because, as Oprah says, when we know better, we do better. So if you have a question or a comment on our topic, call the numbers on your screen right now. Locally, dial 218-788-2844 or call toll-free at 1-877-307-8762. And you can also text us your questions or email them using the number or address listed at the bottom of your screen, and we'll be taking your questions during our entire show. Now let's meet our guest. Dr. Steve Bauer is the Chief Medical Officer at the Human Development Center, and he's board certified in child, adolescent, and adult psychiatry. And Jim Gruba is a licensed psychologist and the supervisor of the crisis response team, also at the Human Development Center. Thanks to both of you for coming out tonight, and thanks to Shirley and Maureen, who gave up their husbands on Valentine's Day so that they could be here with us. And we kind of talking about debunking some of the myths about schizophrenia, and I know like a lot in the lay public, people refer to schizophrenia as split personality. So Dr. Bauer, let's start right there. Is schizophrenia really split personality?
No, that's a common misconception. The true definition of schizophrenia involves having either hallucinations, delusions, along with kind of global paranoia. And in its worst version, schizophrenia becomes a chronic difficulty in interpreting reality. And so one can have auditory, meaning hearing things, seeing things, visual hallucinations, or even tactile or olfactory, feeling or smelling things that other people don't see or feel, and it becomes a pervasive part of who they are. Some people will develop insight, knowing that they are seeing and feeling something that other people won't necessarily respond to. Other people believe they're the only ones that can see it, and they're quite convinced that it is real.
And in fact, lack of insight is often what kind of characterizes schizophrenia. Isn't that right, Jim?
Yes, you know, this is an oversimplification, but when we talk about mental illness, that's a broad area, and we talk about thoughts, feelings, behavior, and so we think about, and they're all integrated, but we talk about depression having something to do with feelings, and schizophrenia having more to do with an interruption of sort of the executive function, our ability to make sense of the world, and that's impacted. And so it's one of the most terrible illnesses in the sense that what we rely on to interpret the world isn't working right, and so it's very terrifying. It's a very, I guess I thought about this tonight, and I want to speak to two audiences maybe. Mm-hmm. On the one hand, I want to say to those folks who don't experience schizophrenia themselves or have family members, I want them to realize and appreciate what a horrible illness this is. And on the other hand, there's the audience of people who are impacted, and I want them to get the message that there is hope there. There is a way to treat this illness, even though it's such a horrible illness.
And part of another one of the symptoms, which you were referring to, is if we think of depression or anxiety as a feeling disorder and schizophrenia as a thought disorder, part of the problems in thinking that people have, which is often expressed in odd and unusual speech that the general public would see then.
Correct. This is one of the illnesses that has probably the most anatomical changes that we can see, which isn't always the case with a lot of the illnesses that we talk about when we use the broad topic of mental health difficulties or illnesses. And so the thought process, the social connection is part of what ultimately loses its usual resiliency in folks that once they experience a psychotic break, and if that becomes a more permanent state of how they function, we see a gradual but serious decline in social functioning.
And that's part of the symptom picture too then, is not just what we refer to as these positive symptoms of hallucinations and delusions and unusual behavior or speech, but also this withdrawing from people. Talk a little bit more about what we in the business refer to as the negative symptoms, Jim.
The terminology can be confusing because when we say positive symptoms, we don't mean positive in terms of good.
Thank you.
Positive in the sense of you can see them. You can, if somebody's speaking to themselves or to unknown persons out there, that's obvious. If they're expressing delusional thoughts, those are what we call positive in that you can see them. The negative are more the stuff that you can't see that can be even more devastating, sort of that lack of enjoyment in life, the lack of appreciation for life, just that emptiness that people can feel with schizophrenia, that real void, that disconnectedness from the world. So that's what we talk about in terms of negative symptoms. Energy, motivation, just enjoyment of life.
And so when we think about some of the stereotypes that are associated with schizophrenia, and some of these stereotypes are evolving out of what people see then, right? The people talking to themselves.
Right, and that's, I think we've seen a real swing in how society has cared for people with schizophrenia. During my dad's time, we went from having a very state hospital-based treatment paradigm to moving to a community-based paradigm, and some of that was to see people more likely to quit their medicine or have more problems and become homeless and have some of those other things, and off medications, the side effects to the medications become very disabling and noticeable. So you can see people who have what we call tardive dyskinesia, where their mouth and lips and other things move, and they tend to incorporate that into their movement, but they're very noticeable, particularly once they become homeless and are out in public and other people know something's up.
And that's part of what makes this such a difficult illness too, is that it really makes you look different from other people, Jim.
It can. One of the things that is true, that working in the setting we work in, we tend to work with folks that have difficulty controlling those symptoms and coming to terms with them. And while schizophrenia affects about 1% of the population, not everybody ends up with a lifelong disabling condition. It's probably not totally accurate, but they used to talk in terms of a third. A third of people who are diagnosed with schizophrenia will recover and be normal part of society, and you won't notice anything different. Another third may struggle with episodes of illness periodically, but generally manage, and another third struggle in an ongoing way and may be disabled over the course of a lifetime, and those are the folks that it may be the most noticeable in. So I think we have to remember that not everybody with schizophrenia is going to be obvious or not succeed. Some folks are going to be totally integrated and you aren't going to identify. Over the years, with medications and better care, that's even more true, that some of those symptoms are able to be controlled and not so obvious.
Here's a viewer calling in from Duluth. A woman asks, what is the difference between schizophrenia and bipolar disorder?
Well, that's a great question. Those are two of what we call the serious and persistent disorders. And if you think of a spectrum where on one end people have all mood symptoms, Bipolar disorder is experiencing periods of extended depression and then extended mania. And as part of that, sometimes they experience psychotic symptoms, but only when they're having mood symptoms by definition. On the other end of the spectrum are people who theoretically may look and have several of the symptoms of depression, but they experience psychotic symptoms throughout, even when they're doing pretty well for chronic schizophrenia. And then in between is something that we call schizoaffective disorder, where we see a mixture of those things. And so someone may have mood cycles, but in the absence of mood, they can still experience psychotic symptoms.
And functioning, let's talk about how some of these symptoms that we've been talking about just translates to problems in functioning in a person's life if you have schizophrenia.
Well, going back to that executive function idea, so I think I want to talk a little bit about the onset, because we know that, like any illness, the earlier you catch something and treat it, the better the outcome is going to be. And it can be very difficult to diagnose what's going on in a young person's life. So typical onset is late teens, early 20s roughly. And so when something starts to fall apart and the person's unable to function, they're unable to succeed at school or work, or relationships start to deteriorate, and sometimes people aren't reporting the hallucinations and what's going on. It's hard to tell what's going on, and so as people, a common thing is for people to withdraw, to start to lose the ability to have those relationships and succeed and not know what's going on. So the process of experiencing that onset and before you get treated can mean a lot of drastic changes in a person's life and a lot of losses. And so there's a lot of disconnectedness from society that starts to happen, from family, and especially if it's not adequately diagnosed or accurately diagnosed.
And a time in our life when we're really learning how to be adults,
Yeah.
And when we're on our way to learning how to be adults. So it's not just that where you are is disrupted, it's that you can't then learn at that point in time either to move forward.
Sure, if we could diagnose really accurately at the earliest stages, it would be easier to treat. But as a 19-year-old experiences some of the things we talked about, there can be lots of reasons. You know, they could be having some other problem. They could be using chemicals. They could be, having relationship problems. It can be hard to identify and diagnose in order to treat.
Dr. Bauer, another woman from Duluth, calls in. What is paranoid schizophrenia, and do medications help?
Great question. We use subtypes to try to differentiate between types of schizophrenia, though quite often some of those subtypes have become more of a which symptom do you have more of kind of thing. So paranoid schizophrenia is probably the more common version of that. There's disorganized, and then there's a very rare version. Some people talk about catatonia still, which is getting literally frozen with what we think of as having this illness, and waxy flexibility and some other things. But medicines are much more effective in that they have identified more receptors than our original version. Thorazine became kind of one of the first medicines that helped people leave the state hospital. And then the new group called Atypicals, Clozaril was the first medicine that really...
The atypical antipsychotics.
Correct. That Clozaril was really seen as a breakthrough for a lot of people that restored their ability to function better in society. And so a lot of people were made better in that, and there are now 8 or 9 of those out.
Unlike the original the original antipsychotics, which took care of those real serious symptoms of hallucinations or delusions or the disorganized behavior, but didn't maybe allow you to function so well in the world in order to control those symptoms, the atypical antipsychotics do a little bit of a better job of both managing symptoms and allowing for functioning.
Very much so. There were lots of studies looking at how we manage anxiety after we get hallucinations somewhat controlled with older typical antipsychotics. Atypicals combine a lot of those kinds of factors into a much more seemingly tolerated and functioning message.
Here's a great question that I want to get to. A woman from Cloquet calls in, is it safe to have young children around someone who has schizophrenia? Mother is in the hospital now and has 3 young children.
Well, I think that is not a yes or no answer. You know, the whole question of are people with schizophrenia dangerous is kind of behind some of that.
That's right, exactly,
yeah, right.
exactly. So that's one of the suppositions
Yes,
that exists in the general community, that people with schizophrenia are dangerous. And so let's say what we know about that.
Okay, well, and I'll let you jump in here, but certainly if someone is psychotic or unable to interpret reality correctly and unable to function, you know, no matter what the cause is, they're probably not going to take very good care of young children. On the other hand, if somebody has an illness that's treated and under control, you know, there's not a lot of risk there. So certainly somebody who's in the hospital, coming out of the hospital, I'd want to know, well, how are things going? Are you in touch with reality again? Are you able to function? Can you take care of children? You know, can you make breakfast and get the kids off to school? Fine, but in terms of dangerousness, I don't think there's generally a real issue there.
Right, and I think Jim's point is well taken. It is really about how well the treatment works for you and how compliant you are then with maintaining that treatment. So what we know is that there are a very small percentage of people who have this kind of illness who, when they don't take care of it, wind up not only being a risk to themselves and having higher rates of suicide, and you know, there's a medical risk in having this illness, but we're talking about dangerousness. And so, you know, most patients wind up having lives, and many of them are mothers, and lots of them do a really good job with their kids when they take care of themselves.
And I think part of what we would want to say as well is that more often people with schizophrenia pose a danger to themselves, sometimes because they have a greater risk for suicide, but also sometimes because of some of the choices that they're making when they're unmedicated in terms of, you know, there are some people who are homeless, and trying to get them out of being homeless, that they have such suspicion about that remaining homeless is, from their point of view, easier for them. We don't think that's easier for them, but certainly if you're in Duluth and you are homeless in the wintertime, that's a risk to you, not a risk to somebody else then, Jim.
Correct. In terms of dangerousness, yes, you're right in terms of the greatest danger is to oneself. The rate of suicide for people with schizophrenia is quite high, and so that's a concern. And again, that goes back to untreated. This is a very terrible illness. We know, we've alluded to this or said this, medications are very effective by and large. They have their side effects. People don't like meds. Side effects are there for almost any medication we take for anything. If you watch the little disclaimer on any medication ad, you probably quake a little bit in your shoes. But so it's understandable that people don't want to take meds unless they absolutely have to. But for a lot of people, they're very essential to controlling the symptoms. Going back to the paranoia, and maybe Steve wants to comment on this, people with the most sort of florid paranoid delusions can be the most difficult to treat in terms of if somebody's paranoid, feeling like people are out to get them or hurt them, they are very unwilling sometimes to take medication. On the other hand, those same people can respond very well, and the medications can be very effective, more so than with some of the folks with more negative, those minus kind of symptoms. So.
Yeah, no, I think you've cleared up that part that I had intended to include in my earlier discussion. So.
Let's move a little bit over to family members and talk a little bit about the challenges that having a loved one with schizophrenia, the challenges that poses for family members, for parents as well as siblings and spouses.
Yeah, you know, I think this is one of those illnesses that is seen by a lot of families as devastating, and it has a lot to do with how difficult it is to understand when you don't have a background or have only heard bits and pieces or stereotypes, which hopefully our show tonight will demystify for us. The role of supporting someone and being there to help them with that is critical for lots of people, and yet difficult to maintain. It's like having somebody with Alzheimer's or any other chronic, very debilitating illness. To whatever degree, when compliant with medications, the patient is able to recover. And so there are lots of parents who are very supportive, and after a while, the individual affected may come to rely on them in a way that helps everybody stay better. Quite often it doesn't go as smoothly as we'd like.
And here's a great question. I'm going to interrupt. I'm not going to let you speak because I have a great question here that you're going to answer instead.
I had a good answer for that other one.
What the well, you can get back to that, but this is my show, you know. So, what is the best way to persuade someone to get screened for schizophrenia? Someone in their 30s. So that's kind of what I want you to address.
Well, in their 30s, that it could happen that that's the onset. I typically would be earlier than that. I think that maybe I don't have a good answer for that question, but it's a great question because that whole issue of, and this goes back to family members, the stigma associated. So people are, you don't want to hear you've got an illness of any kind, particularly one that's fairly severe like schizophrenia. So people aren't eager to be diagnosed. We don't have a system that is a very good mental health system in terms of people be easily accessing the system, easily being diagnosed. That's not easy. So I guess we'd look at that issue of stigma, try to get people to look for help, come in and ask for help for themselves or their family members to get screened. And certainly that's possible. Typically, primary care physicians are the first line of defense, if you will, on lots of things, including schizophrenia and other mental illness. So typically, primary care might be able to identify some of that and help in that process. So a person may talk to their primary care doc first.
Well, and I think a family member may be able to convince another family member to go to a family physician instead of coming to see a psychologist or a psychiatrist. So, so that might be the foot in the door, which is what this family member is looking for. What is the best foot in the door? I certainly think that agreeing to go with people is another way of, like, I will go with you, I will come with you if you will let me come with you. And because if you haven't been to therapy before or you haven't been in this kind of setting, you don't know what that's like. And mostly TV is not helping us out here, except for public television. But
well, and I think that's a great point, because a lot of people that I've seen kind of lead out when they finally get in the room with me and say, does this mean I'm going to have to go to the hospital, or there's going to be an involuntary commitment? And that's the furthest thing away from what any of us are looking to do. The emphasis is on outpatient treatment, and particularly once you've made the choice to come in, it's a lot easier to work with people in that setting and to let them go home and be more comfortable and all those things. So that's really the emphasis for how getting someone to come in and get screened and find out what their options are. And there's no reason that you absolutely have to do what people are asking or recommending for you, but over time you may find that to be more helpful.
let's talk about recovery, because we're going to be running out of time here, and we want to make sure that we get into like what is possible in terms of recovery and what is helpful in recovery, Jim.
Well, I'm going to answer that other question at the same time in terms of family members. One of the things that's true is that somebody with schizophrenia seems to be more susceptible to stress. And we know that at any point with enough sort of deprivation, any one of us will be psychotic if we are enough sleep deprived and under enough pressure. And so somebody with schizophrenia, the recovery environment involves a recognition by themselves and people around them of what they can handle, what kind of stress level, how to make sure you get enough sleep, eat a proper diet. All those kinds of things are an important part of recovery. Another piece, a tip, not unusual for people that have been diagnosed to have alienated or have family and friends, and sometimes that's thought because family and friends don't know how to react. So if we can get rid of some of that stigma, if we can get family and friends to recognize what's going on and accept that and develop a relationship and be able to talk about that and be able to support the person without putting too much stress on them, that's a big piece of the recovery.
Yeah, and I would emphasize, you mentioned diet, nutrition, and general health care. What we know is the only segment of our population that has their life expectancy decreasing are people with serious and persistent mental health problems. And the estimate is that it's 25 years less than the average person's life expectancy. And there's an initiative within Minnesota to try to increase that to only 15 years in the next 10 years, which all gets confusing when we start throwing numbers around. But the bottom line is...
Improve 10 years in 10 years.
Exactly. So the bottom line becomes there are many things that go along that decrease our life expectancy, including cigarettes, other exercise, and all kinds of things. So healthy lifestyles, getting in, seeing your doc, taking medication, and having monitoring is real important.
The other thing we know is that, again, like other illnesses, every episode that's severe enough for somebody to be in the hospital or become really psychotic has a devastating effect, and
we're going to need to. I'm
okay.
cutting you off
All
here
right.
because
Okay.
they're going to be cutting us off. So what did we learn? What did we learn tonight? Schizophrenia is not a split mind. It is having problems interpreting reality, and schizophrenia is treatable, and people function better when they are treated. By and large, most people with schizophrenia are not dangerous to other people. That's all that we have time for tonight. And don't forget to visit us on the web at speakyourmindonline.org, where you can find a schedule of our topics and resource links, and read my blog, the place where I'll answer more of your questions because we have a lot of them on this Valentine's Day. You can also email us your questions about next week's show, our season's finale, when we'll be talking about getting help and getting better, kind of continuing this conversation that we had tonight. I'm Dr. Carolyn Phelps. Thanks for watching, and good night.